Good morning. Today we will start the gross anatomy of the abdomen and pelvis. You have already had the osteology, lumbar vertebra, and some amount of embryology has been done. And I have already started histology of stomach, which is an abdominal organ. So parallelly, we will be studying the gross anatomy as you would have proceeded if you had had section in the. But mainly, we will look at it in the form of long answer questions which you need to, and short bits and very short bits which make part of your exam. So you listen to these lessons as if they were part of your readable textbook, but also as a basis for the dissection that you will quickly do when you come back into college and labs. So the anterior abdominal wall, now this is a familiar territory for all of you. All of us know our anterior abdominal wall. And I would suggest, in fact, I would that once this class is over, you take an anatomy atlas, gross anatomy, or any textbook with good diagram, and correlate for yourself all the surface features which are visible and palpable. Because this is a very, very important area for your patient to be able to glean a lot of medical information, clinical signs, especially when the patients come with symptoms or complaints regarding the abdominal region, but also it may show up some features pertaining to diseases of other parts of the body. So it's a very important region from the view of examination of it. You must become familiar with its surface language. We will go through that again and again. Let us start with the anterior abdominal. That is not working. That puncheted. Alright. Sorry. So you've already seen the thorax, and in the thorax we had a bony rib cage, costal cartilages over here, and we had ribs, 12 pairs of ribs, and in the midline we had a xiphoid process. Now in this diagram, we are showing it as if the anterior abdominal wall landmarks is overlapping the posterior abdominal wall, which consists of your series of vertebrae and intervertebrae, and the bony landmark, the bone of the sacrum and the two innominate bones together, which form the pelvic girdle, anteriorly joined at the pubic symphysis and posteriorly at the sacroiliac joints. Now this part is posterior and these features are anterior. So this is as if they are overlapping, and it's only diagrammatic, but this is just to make you familiar with the landmarks which you have to know. So you have the xiphoid process, visit the T9, T9, T10 level depending on the body habitus. You must remember we are always describing it in anatomical position. That means the patient is standing up, vertically erect, and head facing forward, palms facing forward. Remember. Now, when the patient lies down, some of these things will shift, and we will talk about it when we look at the clinic. But right now, you look at it as the anatomical position. So the superior boundary or border, you can't call it a border, more better to call it a boundary of the abdomen, is where it interrelates or continues or is separated from the thoracic region. We know that attached to this border and to some bony landmarks behind is a huge muscle called the diaphragm. Now this thoraco-abdominal diaphragm is the actual boundary of the abdomen. But if you look at the circumference of the attachment of that same diaphragm, those are the features which separate the thoracic cavity or region from the abdominal cavity or region. So you have the costal cartilages 7 to 12. From here onwards, the CC7 will be somewhere here, and then there'll be 8, 9, 10, and 11 and 12 are floating ribs. So the costal cartilages will be lying free in the posterior abdominal wall. So T11, the rib will come out like that, and the tip of it will be free. And T12, the rib will come out like that, and the tip of it will be free. All those cartilages put together can be called a boundary. The xiphoid process in the anterior midline, which belongs to the sternum, is roughly at the level of the T9, T10. And this would be the anterior boundary, that would be the posterior boundary. So you can see the midline boundaries are much higher, superiorly placed than the side boundaries, which is the entire costal margin coming sloping anterolaterally, and then again sloping posterolaterally, and follow it around the side. Inferior boundary would be where the edges of these pelvic bones, the upper edge, the superior edge of it, are there. So here it would be the pubic bone, the pubis, superior border of the pubis, the pubic symphysis. So this would be the superior edge of the inferior boundary of the abdominal wall, and that at the back is the intertubercle. Actually, this is not the back, this is the lateral margin. If you see the lateral most bony prominence is the the tubercle of the iliac crest, which is about 5 centimeters posterior to the anterior superior iliac spine. So this is the highest point of your uh, uh, iliac bone or your pelvic girdle, and a point joining the two tubercles would be called the intertubercle, roughly at the level of the body of the fifth lumbar vertebra. Now, the iliac crest at that point is the inferior boundary of the abdomen. In the front, it was the pubic symphysis. If you actually see it on a skeleton of your own body or on a volunteer's body, you'll see that the iliac crest height is higher, is superiorly placed. The pubic bone is inferiorly placed. So the midline boundaries are at different heights than the side boundaries, both at the inlet and the outlet. The other feature we need to know is the umbilicus. Now, this is a feature of the anterior abdominal wall skin, and here it is looking as if it is in the middle of nowhere. But if you can imagine that transparent skin, then the umbilicus is a feature which is, if you correspond it to posterior abdominal wall, it will be more or less in line with the vertebral disc between L3 and L4. This also is an important landmark because it is easily seen, available in everybody, and from it we can correlate the other regions and we can come to some information about what is happening with things relative to the umbilical. These three landmarks are very, very important for you to know, to be able to get a sense of what is happening inside the space, even from examining the surface view. So we looked at Ziegfeld process, costal margin, umbilicus, iliac crest, anterior superior iliac spine, inguinal ligament. This you might have heard of in your bone class. It is a fold of aponeurosis, which you will learn with the muscles of the anterior abdominal wall in the next few classes. But this is a semi-rigid boundary between the pubic bone and the iliac bone. In that gap, you have a fold of aponeurosis, which is stretching as a tight, semi-rigid boundary between the two, and that will also form your, or you can describe it as the boundary where the abdomen ends and the next region. You know that on the surface from this one downwards is the lower limb, right? So from the point of view of skin superficial fascia, the continuity, the demarcation between abdomen and lower limb would be the inguinal ligament region. The pubic tubercle is a bony landmark, the pubic crest is a bony landmark, the pubic symphysis is a joint. We have looked at all these in the bone class, but these are the things that we can visualize and we can palpate. We are examining. So we must know these contours. If you see this, we describe the entire abdominal region as certain regions. We will come to that in a minute. But look at the anterior skin of the abdominal wall. This is the thorax region where you have the chest, you have the nipples, you have the sternum in the middle, the clavicles, and here this line is imaginary because you don't see it on the surface. Those are the domes of the diaphragm, left dome and right dome. You can see that the left dome is much left dome, and the right dome will be higher because there is a liver over here. The left dome will be a little variable depending on how full the stomach is and depending on the position of the patient. But what we are seeing is that we've drawn some imaginary lines further demarcate the surface region into reliable regions which the entire medical community will utilize to to examine, to write notes, to report what they find. Why I wanted to show you this is in cross-sectional anatomy, what you will see is that this is the skin and superficial. This is the anterior abdominal wall. That's it. This is the posterior abdominal wall. This is the midline vertebra. So from here to here is the midline of the cavity, whereas the sides are much deeper. From here to here is a cavity, but even here we have this pink region, which is the intraperitoneal region or the peritoneal cavity region, behind which in the midline are some vessels, behind which the left side and the right side are some viscera, and there are some more organs. So all these organs which are behind the peritoneal covering are called the retroperitoneal organs, whereas another bunch of organs will be inside of this peritoneal cavity, potential cavity, covered by two layers of peritoneum, visceral and parietal peritoneum. And these will also be related to this and this part of the abdominal wall. So from here to here, we're calling it the anterolateral abdominal wall because there is a kind of continuity in the way it is formed, the layers which form it, in the thickness of it. So from skin to superficial fascia to three layers of flat anterolateral abdominal muscles, all of them together, and then inside of that there is a, it's not labeled here, but there is a peritoneal sheet. All of these together will form your anterior abdominal wall. In the anterior midline, however, there are vertical anterior abdominal muscles. They're called the rectus abdominis. We will study these muscles in detail in the next few classes. Just orienting you to the topography. What is in the anterior midline? What is on the lateral side? How is the back wall formed? Because they are different. So in the anterior midline, we have the from anterior region from here to here. We have the two rectus abdominal muscles with a gap between them, and that is called the linea alba, where you have the aponeurosis between the two, and the lateral region, half of anterior to half of posterior, it can be called the lateral region or the flank. This is one word you will come across, the left and right flank. So from here to here, or you can go from here to the entire backside. So it is about 5 or 6 inches lateral to the posterior midline. So here you have the bone, and lateral to this, somewhere where we are ending it, you can see, is where these anterior abdominal muscles end. So if you put a dot or dot line here, this whole region can be called the back or the posterior wall of the abdomen. The lumbar vertebra is here. The posterior abdominal muscles, you can see one, the brown ones. They are vertically placed, right, parallel to the midline, just like this, parallel to the midline. And they are differently oriented over here, some of which travel into the lower limb. You've seen the iliopsoas, it starts somewhere here and ends in the iliopsoas tendon in the femoral region. You've seen the psoas muscle. So they are starting from the posterior abdominal wall, traversing through this ilioinguinal region and ending on the femur. So they will be operators of the hip joint. So that continuity is there. The bulk of the muscle will be available in the abdominal region. Just trying to orient you that there will be structures which don't do anything for abdomen or pelvis, which are available here and which must be remembered as contents. So these are the posterior abdominal muscles, and there are vertical posterior back muscles. These have got nothing to do with the abdominal cavity or the region or the organs, but they are, can you see, they are behind the transverse process of the lumbar vertebra. They are in the gap between transverse process and spine. So they are forming the back muscles, very important, because these are the erector spinae muscles which are responsible for extension of your vertebrae, including your lumbar vertebrae. And they're very important in keeping the erect posture for yourself and for your patients. So they will also be seen. This is just a brief orientation to cross-sectional anatomy. That's very important. In clinical field, much of your information will be got through scans and CT MRI scans, and most of them are in transverse axial slices. So they will all be reflecting this topography or this architecture of the way the abdomen is put together. If instead you do a surgical approach and go from this anterior bit is easy to access because it is soft. There is no bony support between xiphoid process and pubic symphysis. There is no anterior bony support. There is no lateral bony support till the vertebrae at the back, and the abdominal region doesn't have ribs either. The soft anterolateral abdominal wall is a great area to be able to do interventions into your patient. That is utilized, but for that we have to know the orientation of how the muscles are, how the fascia is, what is happening inside, what are the tendinous aponeurosis, what is the plane of the nerves and arteries and veins, and that all we will take up from next class on. Today this is just to show you that if you do a cross section, this is what it looks like. If you do a surface to deep approach, then you use the anterior, and you see that in the anterior wall, these are the flat anterior abdominal muscles, vertical anterior abdominal muscles. And on the side, there are the flat anterolateral abdominal muscles. This one is outermost, and if you cut through it, there's another one, then if you cut through it, there's another one. So we will see this. These, if you can remember, which we've done thorax recently only, that there was some intercostal muscle between them. These three layers are also exactly corresponding to the intercostal muscles, but these are now called abdominis muscles. Right? So external oblique, internal oblique, and transversus abdominis muscles. So this look will be there. This is median plane. Paramedian from here to here will have the vertically oriented muscles, which are the recti, and then deep to it and slightly deeper plane and laterally placed from anterolateral almost all the way to the posterior menisci. From here all the way till here will be these three layers of muscles, one beneath. This is what I wanted to correlate between the transection of the abdominal wall, how it matches to or maps to inside structures or underlying structures, and how we look at it or how we name it according to the surface landmarks and features that we see. So what we can see is the nipples. What we can see, what we can feel is the costal margin over here. What we can see is an umbilic. What we can see and feel is the anterior superior iliac spine, pubic symphysis. To some extent, a skin groove here, which is the inguinal groove. Now this becomes therefore the abdominal region for us. But we know that because of the domes of the diaphragm, a lot of the abdominal contents are under the protection of the costal muscle. Technically, they are in thoracic region. Right? Similarly, if there is a full bladder, it is actually a bladder is a pelvic organ, but it would peep up, it would push up, it would fill up and extend into the abdominal region. Similarly, a gravid uterus, a pregnant uterus, would also not be a pelvic organ anymore, but become an abdominal organ. So there would be overlap between contents of pelvic cavity and contents of abdominal cavity and thoracic cavity. Already, when we do a full inhalation, the lungs are expanding and pushing down the abdominal organs, but they stay within the confines of the costal margins. The heart also stays within the confines of the sternal, parasternal regions and the costal cartilages. So that doesn't overlap downwards, but abdominal organs overlap upwards because of the domes. Just remember this when you are examining and when you are interpreting the cross sectionals when you see at different levels in CTs. So, what you need to know when you examine a patient, which you should probably revise in an atlas and on a living body, yours or a partner's. The xiphoid process, we already know this. 2 is the costal margin. 3 is the tip of the ninth costal cartilage. Now we know that 9, 8, 7, they join up with each other, right up to the joint between the body and the xiphistome. If you palpate it, that's how it is. But at this point, lateral to the muscle of the anterior abdominal wall, if you have a candidate or a patient or a person with well developed, well exercised, well toned anterior abdominal muscle, you can see that you can feel a lateral margin that will more or less approximate to the tip of the ninth costal cartilage, a paramedian space. Tendinous intersections. You feel the muscle, you may even see it in a toned abdominal wall, that there will be a fleshy projection and then there will be a dip, there will be a depression and then another fleshy projection and another depression. So the depression between two projections would be a tendinous intersection between sections of the same muscle rectus abdominis. This is the right side, this is the left side. Then the umbilicus is a visible and very easy landmark. Iliac crest. You will feel the bone, you can sometimes see the bone, the iliac crest. The anterior superior iliac spine, which is easily visible. 7. 6 is the whole crest and 7 is the spine. Linea semilunaris is the line, which is the lateral boundary of the rectus muscle. The linea alba, which is a midline vertical slight depression, you see right from xiphoid process up to pubic symphysis. Not very clear in some areas. It may not be, alba actually means white. It may not actually be white, depending on the skin tone of the person, but it will be slightly depressed because it is the gap between the bulging of the left and right rectus. It's exactly the anterior goes through the umbilic. This linea alba becomes an important landmark. Why we call it alba is when we open the skin, it is a tendinous intersection. It is not a reddish muscle belly, but a white tendinous intersection. So, and it is also an avascular plane because very few, almost no blood vessels come right up to the midpoint. Very, very fine capillaries only. So in one sense, it is a bloodless plane, very important and very useful for the surgeon to access and to cut through. So the linea alba is an important landmark. Then you have the inguinal ligament, which is stretching from 7 to 11. This 10, number 10, is the inguinal ligament. I told you about it in the previous picture. Then you have the pubic tubercle. Here, it is a bony landmark. It is palpable, usually not visible. A pubic crest, that is also palpable. And a pubic symphysis, which is the midline point for the linea alba insert into. This pubic symphysis is actually a joint. Symphysis, you remember, partly movable joints. So we actually, in males, it's almost immovable. In females, especially during, just before and continuing through pregnancy, it's a semi-mobile joint. It becomes more flexible to allow for expansion of the pelvic girdle or to accommodate child. But what you need to remember is that it is a midline structure, and it is a bony landmark which can be palpated, which will be used as a reference point for measurements which you take for surface landmark. So these are the structures, bony and skin landmark, which you must remember to the anterior. So what are the lines we see? We already talked about the linea alba is in the anterior line. It is a connective tissue tendinous wrapping. That is exactly what it is. And it is therefore beneath the skin. It does not belong to the skin. So we call it a skin landmark. Then we have the linea semilunaris. This is a skin landmark because you see it as a depression. It is along the lateral border of the rectus abdominis from the tip of the ninth costal cavity. We saw it. Then we have the linea transversalis. This is nothing but the horizontal furrows or the transverse furrows we saw between the sections of the rectus abdominis. The linea alba, you may get it as a short note. You must know about it, where it extends from where to where, what it lies between, and what is it. You will understand better after you study the three anterolateral muscles, one beneath the other. They are going to be muscular like this up to a certain degree. And then when they approach each other to the midline, they become tendinous. The muscle tissue goes away and gets replaced by ligamentous tissue, strong connective tissue. And those connective tissue fibers intersect with in the anterior midline. So this fusion of the aponeuroses of the three pairs of muscles, transversus abdominis deepest, internal oblique outside that, and external oblique outermost, three of left and right side fuse with each other and form a tight tendinous intersection. This is what the linea has. Now let us look at what are the abdominal quadrants. We can, for purposes of description and sharing information with the entire medical community, has devised some artificial lines and demarcations, better able to understand what is in which place normally under normal circumstances, so that then we can tell if something abnormal is happening or not. So earlier we used to think, or it was common to think in terms of quadrants, that entire anterior abdominal region with all its bony landmark, its skin features. We divided into 4 zones depending on 2 intersecting lines. The lines are the vertical midline, which we saw, and the horizontal line through the umbilicus. At level of umbilicus, it is not just a horizontal line on the surface of the abdominal wall. They will intersect at the umbilicus, and it will divide that whole area into 4 quadrants. So there will be upper left, upper right, lower left, and lower right quadrants. But this is not so much used either in basic sciences like anatomy or in clinical sciences. Rather, we look at 9 regions of the abdomen by using 2 vertical lines and 2 horizontal lines. So there are 9 regions caused by or created by 2 pairs of artificial planes. You must remember these lines do not exist. These straight, nice, geometric, mathematical lines do not exist in nature, in life. These are some things we have devised for you to be better able to predict what is in any one of the regions. The 2 vertical planes are the left and right lateral plane. Mid clavicle, you can see the clavicle, Take the midpoint and just drop a vertical from there. Comes all the way and it seems to join or cut the mid-inguinal point. Okay, so the midpoint of the line joining the anterior superior iliac spine and the pubic is midpoint, and the midpoint of the clavicle are in a straight line, more or less. So this becomes the right lateral plane. This becomes a left lateral or left and right mid-clavicular planes. These are the two vertical, two pairs of planes. The other pair of plane is this one and this one, horizontal plane. Need a horizontal line to go through, which we have traditionally called transpyloric plane. We can't see the pylorus on the surface anywhere, either from the front or the back. But we know that it cuts through at the level of the ninth costal cartilage. There was a place here, ninth costal cartilage. So if you join the two ninth costal cartilages, you get a transpyloric plane, which will go through the pylorus of the stomach, which is why it's called transpyloric. And it will also go through posterior abdominal wall. We will see the correlation. Transtubercular plane is, we had already identified that the highest point of your iliac crest is called the iliac tubercle. So joining this and this is exactly where the soft abdominal wall ends and the bony part comes, right? This transtubercular plane. So one and two horizontal planes. Between these two and these two, we get 1, 2, 3, 4, 5, 6, 7, 8, 9 regions. So these 9 regions are created by us for the purpose of studying the contents of the abdominal cavity. The transpyloric or Addison's plane is anteriorly midway between jugular notch and pubic symphysis. Let's go. So jugular notch. If you measure it and take a midpoint, does it look almost the middle? Then you get the transpyloric, right? Or another way of looking at it is between the xiphoid and the umbilical. Is it more or less half? From here to here and here to here, more or less half. So midway between jugular notch and pubic symphysis, or between xiphoid and umbilical, this plane is horizontally cutting the abdomen. In front, the plane passes through tips of both the ninth costal. Posteriorly, it corresponds to lower body of L1. You can't see the vertebrae, but if this plane were to hit the back wall, it would go through the L1 vertebra. This is very important. It is a standard landmark, no matter what the position of the patient. This plane is very critical for as a baseline cut to the abdominal. So you must know everything. Then structures that lie at the level of the transpyloric. And one of the reasons why this plane is given so much significance is because it goes through several important structures. So, for example, it goes to the pylorus of the stomach. As the name itself, pyloric end of the stomach is a fixed point, just as the esophageal end of the stomach is a fixed point, because that is where the esophagus is going through the muscular diaphragm to come into the abdomen and then become the stomach. That is a fixed position, doesn't change much even with, but the pylorus is an even more fixed position, and relative to the other moving around organs there, this is a fixed one. We must remember that the intraperitoneal organs like the stomach and stomach, so they're suspended by a flap of mucus. They are mobile. They can shift around depending on the position. The pylorus stays constant and steady, which is why we're using it as a landmark or a reference point. So the pylorus of stomach goes through it. Then you get the fundus of the gallbladder on the right. You get the origin of the superior mesenteric artery from the midline. You get the hyla of both kidneys, left and right kidney, the hilum of each cut through by the transpyloric. And we already know that lower end of spinal cord ends at L1. The transpyloric plane, the substance of the spinal cord finishes at cauda equina nerves in the subarachnoid, are visible when you take a transection, a view such as a CT or an. Please remember at least these 5. There are many other, but at least remember these 5 for transpyloric. So we looked at all these. Now let's look at this. The transpyloric or Addison's red dotted line is going through L1 lower. Subcostal plane is another plane we talked about, which means that actually it should be in touch with. It is a plane corresponding to the lowest points of the costal. So your ribs come all the way down to here, and then they go high. So the inferior most plane just beneath the costal margin is the subcostal plane, and this is at a lower level than transpiral, roughly going through L3 level. This is important. In the earlier days, for the 9 quadrants, we used to use subcostal plane. So transpyloric is difficult to predict where the ninth costal cartilage. Concept came up a little later. Earlier it was very easy. The highest point of the lower bone, iliac crest, the lowest point of the higher bone, costal cartilage. We had a subcostal plane and a transtubercular plane. So between these there was a narrower region. So this 1, 2, 3 regions would be narrower. From here to the domes of the diaphragm there will be a lot of space here. And beneath this also comparatively there will be a lot of space up to the pubic symphysis. These three regions would be narrower in height. But nowadays we don't use a subcostal plane in description of the lung regions. We use only transpyloric. So please remember that. But don't get confused. There is something called subcostal plane. It has its own importance. It goes through level of L3. Just remember it is lower, 2 vertebrae lower than Addison. Then you have the transtubercular plane. I've already described the tubercular plane. And you have the tip of the coccyx. This obviously you don't see here. You can only see from the back. But you remember that below the level of the entire vertebral margin is the pubic region in the standing position. The pubis is more inferior than the entire vertebral in terms of correlation between anterior abdominal features and posterior. So this is the bony landmarks and planes of the abdomen. Subcostal plane drawn through the most dependent part of the 10th rib and the costal rib. Traced behind the plane passes through the upper body. Why are we saying 10th rib? Because the lowest part of the costal margin is formed by the 10th rib and its costal cartilage. Right? Costal cartilage starts here itself. The rib comes, curves, and from here to here is costal cartilage. Then 9th joins, then 8th joins, then 7th joins, then 6th is joining up to the side of the body. Alright. The intertubercular plane, which we already talked, is through the tubercles of the uterus and goes to upper part. You remember L1, L3, L5, L6. This is what it will look like in a live patient. We'll have the two vertical planes, which are the mid-clavicular, mid-inguinal, left and right lateral planes. It's enough. Then you have the transpyloric and the transtubercular. So now let us name the regions. In the midline, between the two verticals is the epigastric. To its right is the right hypochondriac region. Hypochondria beneath the ribs. Costa is ribs, chondra is the costal cartilage. Right? So beneath the costal cartilages region on the left side, the right side. Then the next one, between the two horizontal planes, central region is umbilical region because it contains umbilicus. The umbilicus may not be central in it, but the whole region is the umbilical region. And to its right, you have the right lumbar, left lumbar region. All this lumbar, some books will call it lateral. And we already said they use the word flank. So these are the words which we use for right lumbar and left lumbar. Then we have the hypogastric. Now, the word gastric seems a little weird, a little quirky here. The thing is, the stomach is up here, but a full stomach in some people with a thin bodily habit, when they are standing, stomach can come right till here, but it never crosses this plane. So this region is under the stomach, hypogastric. Right? That's a strange way to name it. If you can't remember, just call it pubic region. Pubic is very easy. Pubic or hypogastric region. To the right of it is right iliac. The bone here is ilium. So right and left iliac. Also called right and left inguinal regions. Easy enough to remember the names. So we just for sake of remembering what is in each, we just numbered it. You just remember what from right of the patient to left of the patient. 1, 2, 3 top, 4, 5, 6 middle, 7, 8, 9 bottom, and we'll describe what is there in each quadrant from the next diagram. I'll try to come back and forth, but let's see. Alright, so this is easy enough to understand. These are the two vertical planes. These are the two horizontal. So the contents of each of these abdominal regions. The right hypochondriac, this one. Right? You see, this is the dome of the diaphragm inside the rib cage. This is the rib cage outside. And in the gap between rib cage and dome of diaphragm and posterior abdomen, big organ on the right side is the liver, isn't it? Also, we don't see here because it's being overlapped, but behind the liver there will be the right kidney. Left hypochondria. This one. You have this thing again, rib cage. This is the left dome of diaphragm. In this gap will be the mainly the stomach, but also the left lobe of liver. This whole organ is the liver, right? This is its right lobe, this is left lobe. This organ's good amount of it, small amount of the tip is inside the left hypochondriac region. The entire stomach, this organ is the stomach. The entire upper part of stomach is the left hypochondriac. And the pancreas, we don't see. Pancreas is behind the stomach. Good part of body. The body of the pancreas is in the middle, but the tip, the tail of the pancreas will be the left hypochondria. Also, the spleen, which is related to the left border of the stomach, near the fundus of the stomach. So it is within this region, and the left kidney, just like the right kidney. So these are all the organs in the left hypochondria. The epigastric region seems to be quite big. This one has a diaphragm in the artificial plane, transparent. It contains this liver, contains the stomach, and it contains, like I said, behind the stomach, the body of the pancreas. The body is here, tail of pancreas is in the hypochondria. Then let's come to right lumbar region. Right? From this. So all you can see, mostly what you can see is the ascending colon, right? But it will also have loops of small intestine. I've not mentioned it because small intestine tends to stay in the middle, doesn't come more laterally, but it can be here, And you have this right lateral or lumbar region containing the ascending colon. The left lateral, here you will have the descending colon. But you will also have a few loops of small intestine. So these are 5 regions which we saw here. 1, 2, 3, 4, 6. We didn't look at 5. So you're getting a sense of how we correlate the regions to the structures. Now we look at the umbilical region, the middle one. Right? On the surface, it contains the skin scar called the umbilical. Inside, mostly contains loops of small intestine. It also contains this transverse colon, which is the large intestine. The right inguinal. This is 5. So this was 1, 2, 3, 4, 6 in the previous slide, and 5 in the right. This is 7, 8. If you look at 7, is the right inguinal or iliac region of the ileocecal junction, where the ileum, small intestine, joins this large intestine, and at which point you have the junction of the beginning of the appendix. That's important for those of you who have had appendix removed. You know that is where your surgery would have. The left inguinal or iliac region is a corresponding side, the 9th region. There's no ileocecal junction here, so there is no appendix, but you have the sigmoid colon, part of the large. Sigmoid colon is here, transverse colon is. Then you have the hypogastric region, which I said is also called the pubic region, middle, lowermost. Again, loops of small intestine, lots of loops of small intestine will be coming to the urinary bladder when it is full only. When it is empty, it doesn't come into it. It's a pelvic. And pregnant uterus, again, a non-pregnant, normal intercycle uterus is pelvic organ. When we look at pelvic later, we must remember that the abdominal cavity is continuous with the pelvic cavity. Beyond these boundaries which we have discussed in life, in nature, there is no single abdominal cavity. It's an abdominopelvic cavity. The abdominopelvic peritoneum. For purposes of description, we have divided it and we are demarcating that these organs are seen in these. There are other contents also. What we did here is this was the stomach, this was the duodenum, we cut out the entire small intestine, the ileocecal junction. Kept the large intestine, we cut out the entire transverse. We kept the descending and to some extent the rectum. So if we throw out the loose bits of the bowel, what we see is posterior abdominal structures. So you're seeing the aorta dividing, you're seeing the inferior vena cava. These vascular structures are also contents of the quadrants. So for example, these two are parts of the umbilical quadrants. We shouldn't forget that they are there. We will take care of them, or we will give importance to them once we come to retroperitoneum. These structures are so far behind that you cannot see them or feel them, so they're overlapped by all the viscera, the digestive viscera in life. But sometimes you may have a huge aortic aneurysm, or you may have a huge lymphoma of the lymph nodes surrounding the aorta, which may present as a big abdominal mass. And you have to differentiate whether it is belonging to the small intestine, or to the back of the anterior abdominal wall, or to the front of the paravertebral muscles, or to the artery, or to the vein, or whatever. Right? And there will be ureters from the kidneys. Ureters will be coming down like this. You have to figure out whether the mass you're feeling, or that obstruction, or the hardness, or discoloration, pulsation, anything you're feeling is belonging to one viscous area. But you can comfortably rule out other viscera. For example, if in this region we don't expect a urinary bladder problem, right? Or we don't expect a liver problem. Like that, you can rule out some things, and you can try to confirm other things by knowing the regions and the quadrants of the abdomen. I haven't labeled anything here, just to give you an idea that there are further contents. We are not looking at it at the moment. The ones which I've already mentioned, please look at and remember. So, the anterior abdominal wall is firm and elastic. It consists of 8 layers. From superficial to deep, these are skin, superficial fascia, 3 layers of muscle, the fascia transversalis, extraperitoneal tissue, and parietal layer of peritoneum. This was the picture I showed you earlier also. We only looked at the thickness from here to here. Behind that is contents of the peritoneum. Same thing, thickness from here to here. Today I only talked about surface features, only what you see and feel from the outside. We didn't even go beneath the skin. So just to give you a revision, that in looking at anterior abdominal wall as an access point, as an information, and as a description to share notes and convey information between different parts of the healthcare community, or healthcare team understands this region in this standardized way across the world. And we must stick to the terminology and stick to this understanding. It should become deeply ingrained in you. You should never forget these definitions and these descriptions. That is the thickness of the anterior abdominal wall, which we are talking about in 8 layers. To learn the layers later, I'll just leave you with this skin, the topmost layer. What we could see were visible crease lines, linea alba, linea semicularis, linea transversalis. We already talked about. Extra things which may be seen, may not be seen. Line of Venus, not very important clinically, but it is a semilunar line with a concavity facing upward, seen mostly in females, between the umbilicus and the, that means in the hypogastric region or the pubic region. You may see another transverse line with a slight concavity upwards in female anterior abdomen. In older women who have had many pregnancies, multiparous, the lower part of the anterior abdominal wall may show a number of irregularly branched white lines. On the skin, you will see these demarcations. They occur because of degenerative fibrosis of the subcutaneous fat. The fat beneath the skin, subcutaneous fat, which comes under superficial, it gets stretched as much as the skin gets stretched as the uterus grows with the baby inside. When that skin again regresses back to its non-pregnancy, post-pregnancy, this stretched out fat undergoes a little bit of degeneration and becomes fibrosed with a lot of fibers replacing the fat. That undue stretching has given rise to this adjustment phenomenon. And those fibers beneath the skin look like white lines, pale lines. They are not the color of skin, they are paler. This are called linea gravidarum. Gravida means pregnant. So these indicate that the patient has undergone at least one pregnancy. They usually don't happen with anything else. But it can happen with a slow growing huge mass abdomen. It is not a pregnant uterus, but some other mass. It's rare, because if there was a mass which was growing, then by the time it is a little palpable, the patient will come to you with it. It won't become a uterus. Rarely can happen, but we never consider that. We always call it linea gravidarum. The first and most obvious cause, especially in a woman of childbearing age between the ages of 15 and 55, would be linea gravidarum. Usually doesn't happen with a single or one or two. With more than 2 or more pregnancies, it is more likely to be seen in the lower anterior abdomen of men. So this is a skin features, and we looked at a scar called the M.B.B.S. I will look at it in more detail, and we will talk about the surgical approach of the applied anatomy of all the surface features. After you have studied how the fascia is disposed, what are the cutaneous veins, arteries, and nerves? Because those all become important in deciding how to put a scalpel and where to cut and where not. So we'll look at that in the next after all those classes. So for today, we've looked at anterior abdominal wall, the planes, the quadrants, the regions, and in the next class, we'll look at the supply. So thank you. In my next class on Saturday, we will continue the histology. We already looked at histology of stomach, and we looked at small intestine. We said duodenum, jejunum, ileum, villi, and Peyer's bacteria. So we will look at large intestine, colon, and